afternoon, everyone. Uh, Welcome to webinar number 17 of the ISBMT Patient Support Group webinar series. We welcome you all for this initiative on behalf of Indian Society of Blood and Marrow Transplantation, where we enable and empower patients through their journey towards a cure through a bone marrow transplantation. The topic of discussion today is importance of mobility in critically ill patients undergoing bone marrow transplantation. As all of you are aware, uh, bone marrow transplantation takes a toll on most of us as patients and as doctors. Uh, as caregivers, we see patients neglecting their initial mobility as a preparation towards transplant, and we try to make sure that patients are active before transplant and even after transplantation. So, to educate all of us, including caregivers, ISBMT has organized this schedule in this webinar in association with our sponsors, Genova, Cipla, Novartis. We thank them. Uh, as members of patient support group, Dr. Venkatesh Egbote, myself, that is, welcome you to this webinar series. I'm also joined by my other esteemed colleagues, Dr. Silki Jain, who is a senior bone marrow transplant physician uh, at ESI's Medical College, Faridabad. Then Ms. Riyad Daruwala, consultant psycho-oncologist. Ms. Suman Kubal, nursing in charge at BMT Heads at ACTRIC. We have our esteemed mentors, Dr. Tapan Saikia and Dr. Naveen Khatri and Dr. Revati Raj to thank for this initiative. Now it's my honor and privilege to welcome the speaker for today, Dr. Mahua Chatterjee. She is Officer in Charge, Physiotherapy and Rehabilitation Services at Trek Tata Memorial Center, Navi Mumbai. She will be sharing her thoughts and educating us in how to uh, how important it is and how we should go about in terms of addressing mobility in our bone marrow transplant patients. Over to you, Dr. Mahua Chatterjee.
Um, Thank you so much for the nice introduction. So, thank you for having me here. And I'm really very much extremely happy that you have considered this very important topic for sharing and for discussion with the caregivers and patients. So, I will start sharing my screen. Is it okay?
Yes, madam.
Uh, I think the screen is,
Yes, you can proceed, ma'am.
I can proceed. Okay, fine. So in today's audience, how many of you are patients and caregivers here?
Madam, most of them are patients, and as panelists that we have joined, we are all caregivers, although we have a few doctors also joining in.
So
Yes.
I will continue in English and Hindi as well.
Yes, yes, please. For now, we can continue in English, and whenever you want to use certain terminologies, you can go ahead and address in Hindi as well to explain yourself. Most welcome.
Okay, yeah. Thank you so much.
My pleasure.
So we'll discuss the importance of mobility in bone marrow transplant patients. And as we know that bone marrow transplant is divided into a few phases. It starts with the pre-transplant phase and then the conditioning phase, engraftment phase, and then post-transplant phase, where the transplant is done and still the patients are on follow-up. So mobility matters in all phases of bone marrow transplant. So in the pre-transplant phase, when a patient is selected for bone marrow transplant, they are already having the sickness. They are having the problem, the cancer, and the disease. So their aerobic capacity is reduced, pulmonary complications may be present, muscle weakness is there, and they develop a poor posture also. So all these things needs to be taken care of so that we can prepare the patient for the transplant. Then in the conditioning phase, the patient may undergo chemotherapy uh, uh, or full body radiation. So all these causes generalized weakness, fatigue, mobility gets reduced because they really feel very weak and cannot move much as they used to do in their day-to-day life before the conditioning phase. Respiratory conditioning, respiratory complications are also common, and chemo-induced neuropathy also is present where the patients they feel like tingling sensation, burning sensation, weakness. So all these things happen due to the side effects of chemotherapy. Uh, what we say chemo-induced peripheral neuropathy. And then when the actual engraftment process done, that is the most critical time when the engraftment is happening, and the patients are really really very sick at that point. They are actually confined to a bed inside an isolated room. Severe deconditioning happens, and not only muscle weakness or pain, but balance is also affected. If someone is not moving for a long time, their balance is also gone, and overall the functional independence, whatever daily living activities they used to do, those all get compromised. They may have breathlessness, shortness of breath, difficulty in breathing, muscle and joint pain. And in the post transplant phase, then there are different set of problems. The most common problem what we address is GVHD, that is graft versus host disease. I think all of you patients you know, those who have undergone allogenic transplant face it. And then joint stiffness, osteoporosis, that is the loss of minerals from the bone when the bone becomes very weak and brittle. Also there is weakness, exercise tolerance reduces a lot, and overall the quality of life get is decreased. So all these problems are there, and which can be addressed through proper physiotherapy and a mobility program. So we will see one by one. So, as I said, that if someone is just not moving, confined to a bed for a long time, just not moving causes lots of complication. So, the major complication which may uh, prove to be fatal also, जान भी जा सकता है, वो है respiratory complications. And then risk of DVT. DVT is deep vein thrombosis. If we are not moving our leg muscles or our limbs, then there is a chance of clot formation. Diffuse atrophy of muscles, that which means the muscles lose their muscle girth, and as a result the power of the muscles also drops. There is pain, restriction of joint range of motion, joints don't move, can't move much, which is stiffness. Bone density reduces. The action of bone is to bear weight, and if we are not moving, we are not standing, we are not walking, the bone loses mineral from its composition, and bone density decreases. Also the balance gets affected, as I said, so there is a risk of fall, and the functional dependence grows. So coming to respiratory complications, if someone is immobilized for long time, so what happens, breathing becomes slow. सांस हम लोग पूरा नहीं ले सकते हैं, भर के नहीं ले सकते हैं, एंड द लोअर पार्ट्स ऑफ लंग डज नॉट फुल्ली एक्सपैंड. शैलो ब्रीदिंग हो रहा है, छोटे छोटे सांस ले रहे हैं, और वो पूरा लंग्स की बेस तक नहीं पहुंच पाते हैं. तो अंदर का जो छोटे छोटे बैलून लाइक स्ट्रक्चर्स है एल्वियोलाई, दे डोंट एक्सपैंड. तो एज ए रिजल्ट क्या होता है कि ये जो पार्ट्स है ये कोलैप्स हो जाते हैं. इसको हम लोग एटेलेक्टेसिस बोलते हैं. और most of the cases the patients have weak cough. Normal people will cough out the secretion any problem is there, we even inhale a dust or something, we will cough. But those who are immobile for long time and they are weak due to the disease, they have a decreased cough reflex, so they cannot cough out the mucus. और कंटिन्यूअस होने की वजह से, इमोबिल होने की वजह से, द म्यूकस गेट्स पूल्ड इनटू द डिपेंडेंट पार्ट्स ऑफ द लंग्स। जो भी पार्ट बेड के साथ अटैच्ड है, जो ग्रेविटी के नज़दीक है, वहाँ पे सिक्रेशन जमा होते रहते हैं। जहाँ पे सिक्रेशन जमा होगा वहाँ पे इन्फेक्शन होगा। सो द म्यूकस पुलिंग द लंग्स विल कॉज चेस्ट इन्फेक्शंस एंड दैट कॉजेज न्यूमोनिया। So that is a major problem, which is because of prolonged immobilization. Next is muscle wasting. हम लोग सोच भी नहीं सकते कि कितना जल्दी हमारा मसल्स अपने जो गर्थ है वो लूज करता है। It begins within 48 to 72 hours of immobility. If a person is immobile for only 2 days, there will be some muscle wasting noted. And the strengths drop 10 to 15% per week. So muscles, if they don't work, they don't contract, they start losing their girth. And as a result, their power also reduces. So muscle weakness happens because of the patient is critically ill and is admitted in the ICU. So ICU acquired muscle weakness is there. And also there can be weakness because of steroid. Steroids is a very essential drug that is needed for critically ill patients. But इसका side effect ये होता है कि myopathy होता है, which is known as steroid induced myopathy. ये दोनों के चक्कर में हमारा मसल्स बहुत बहुत वीक हो जाते हैं। एंड द वीकनेस इज फेल्ट मोस्टली इन हिप्स एंड थाइज, shoulders and upper arms, which we say proximal muscle myopathy. The muscles which are proximal, close to our body, central part of the body, they are more weaker than the distal parts. And the problems faced are the difficulty in standing from sitting or lying position. So patients often complain करते हैं कि टॉयलेट सीट से उठ नहीं पा रहे हैं। तो ये एक क्लासिकल एग्जांपल है proximal muscle myopathy. Then stairs climbing is difficult. The difficulty in lifting arms overhead. 90 डिग्री तक मुश्किल से ले पा रहे हैं, पर उसके आगे ऊपर नहीं जा रहा है। मसल फैटिग हो रहे हैं, बहुत टायर्डनेस आ रहा है। एंड ऑफ कोर्स फ्रीक्वेंट फॉल्स, पावर ही नहीं है तो खड़ा ही नहीं रह पाएंगे। सो द नीज बकल एंड द पेशेंट्स टेंड टू फॉल। And the then next problem of immobility is pain. Bone and muscle pain from tissue damage and inflammation. Na chemo, radiation, medicines, disease, everything causes a inflammatory response to your body. The nerves can be get irritated and that can cause a neuropathic pain. There is pain due to the engraftment process also, and it is usually deep bone pain. The pains in the deep bones, bigger bones, they cause pain. And of course psychosomatic causes. If someone is confined in a room for a long time or bedridden, they obviously feel lots of stress, emotional upheaval, and psychogenic causes which produces pain. So pain is basically a defense mechanism of our body. So the muscles go into tension when there is a pain. तो हम लोग जब बोलते हैं कि आप थोड़ा सा मूव करिए, थोड़ा उठ के बैठिए, बट द पेशेंट्स विल फील अ काइंड ऑफ एप्रीहेंशन कि मुझे दर्द होगा या दर्द हो ही रहा है, तो बॉडी पूरा टेंशन में आ जाता है, मसल्स गेट टेंस्ड। सो एज ए रिजल्ट द मसल्स डोंट मूव एंड देयर इज रिड्यूस सर्कुलेशन। तो सर्कुलेशन ही नहीं होगा, मसल्स, नर्व्स, होल बॉडी में अपना सर्कुलेशन नहीं होगा, तो उसको न्यूट्रिशन नहीं पहुंचेगा एंड द मसल्स गेट इन्फ्लेमेड। उसकी वजह से और मूवमेंट में प्रॉब्लम हो रहा है, और जितना मूवमेंट हम नहीं कर रहे हैं, बॉडी स्टिफ हो रहा है, उतना पेन जनरेट हो रहा है। और फिर पेन हो रहा है तो मुझे फिर से डर लग रहा है, मसल फिर से टेंस्ड हो रहे हैं, फिर से मैं मूव नहीं कर पा रहा हूँ। तो ऐसे एक क्रॉनिक विसियस पेन साइकिल बन जाते हैं। वी हैव टू स्टॉप दिस साइकिल, वी हैव टू ब्रेक दिस साइकिल। तो इसका एक ही इलाज है, एक ही उपाय है, वो है मोबिलिटी. Next is deep vein thrombosis. That is again a very, very critical complication of immobility. Someone who is not moving may think or may get a swollen leg like this or a swollen arm like this. It mostly happens into the legs. So the leg becomes swelled and painful, redness आ सकते हैं. और ये क्यों होता है? क्योंकि डीप वेन्स में ब्लड क्लॉट हो जाते हैं. और ब्लड क्यों क्लॉट होते हैं? क्योंकि हमारे जो मैकेनिज्म है ब्लड को ऊपर पहुंचाने का, वो है डीप मसल कंट्रक्शन. when we walk, when we move our legs, then only the bloods will go upward. कहते हैं कि हमारे बॉडी में दो हार्ट है, एक है अपने चेस्ट पे और दूसरा है कफ मसल्स में. You have all seen any liquid, any fluid flowing from up to down. Has anyone seen anything flowing down to upwards? No. पर हमारे बॉडी में जो ब्लड है वो पैर से नीचे ऊपर हार्ट तक पहुंचता है. कैसे पहुंचता है? बिकॉज द मसल्स इन द कफ मसल्स दे वर्क वेरी स्ट्रांगली. So the blood gets circulated upwards because of the strong contraction of the muscles. और ये तभी होता है जब हम उसको move करते हैं. So the patients if who are not mobile, confined to the bed, cannot move their legs, so there will be sluggish circulation, there will be clot, blood clot will form, and it may be fatal if a part of the blood clot is dislodged and it blocks an important vein or important part of the body. If a patient suddenly develops breathlessness, and even the patient can die also because there has been a pulmonary embolism. और ये embolism मतलब क्या है कि ये blood clot का जो part है ये dislodge होके एक एम वेन को या आर्टरी को ब्लॉक किया है, उसकी वजह से वो सांस नहीं ले पाया और acute respiratory distress syndrome हो गया. So the idea is to बी मोबाइल, मूवमेंट करते रहना है पैर का. इफ द पेशेंट इज एबल टू डू ऑन हिज ओन, दैट इज वेरी गुड. वी ऑलवेज encourage active movement, but if it is not possible, at least passive movement. केयर गिवर्स जो है उनको हम लोग सिखाते हैं कि आपको पैर का मूवमेंट उनका करके देना है, करते रहना है बीच बीच में थ्रू आउट द डे many times, so that the blood circulation remains unhampered. So ये इतना ही important है. Next important problem is bed sore, pressure sores or bed sores. There are body parts which are mostly, most prone to develop bed sores if we do not move. The pressures are mostly at the back of the head, shoulder, elbow, buttocks, legs, and heels. Even if we are lying on the sidewise, then ear ke piche, shoulder, elbow, hip, thigh. If we are sitting just like this, then also in a dependent position, the pressure is more on these pressure points and these parts become sore. The pressure sores and bed sores are a very um, critical problem. One bed sore takes at least 6 months to get healed. And if bed sore develops, then it causes further immobility because then sitting becomes very difficult, standing becomes very difficult, turning becomes, positioning becomes very difficult. So, bed sores or pressure sores can be avoided only by regular turning, exercises, movement. So, again, mobility is the key problem shooting thing. Next is balance loss. As I said that we have our writing reaction in the body. Our body makes ourselves safe when we are making any transition from sitting to lying or lying to sitting, sitting to standing, or when we are walking. So ये balance जो अपना है body का, ये तभी काम करता है जब हम इसको practice करते हैं. But if we are lying throughout the day or we cannot move, then our balance slowly gets deteriorated. So first thing to go is the standing balance, then sitting balance. So all these things, and dynamic balance is when we manage our balance from one transition phase to other, like coming from sitting to standing, ये जो balance है, or when we are walking, so the balance we are transferring from one leg to the other. तो ये जो dynamic balance है, ये सब अपने brain जो है ये इसको control करता है. But if I am not using that balance centers in our brain, we are just not able to move, or we are not moving, we are having pain or apprehension, so our balance gets affected. So the idea is to definitely strengthen the muscles as well as balance training. Balance training is very, very important. In many of the cases, the patients cannot walk not because they are weak, because they are falling. And once they are having that apprehension, or once they feel that I will fall, they will not move. They will think that it is not safe. So balance training is a very important part of the movement and to maintain the mobility. Also postural training, how your body parts are aligned, that maintains your balance. And that can be only done when you are doing your regular movements and doing the exercises properly. So mobilization कैसे करेंगे? First is that critically ill patients, they may feel shortness of breath, they may have cardiovascular insufficiency. So mobilization हम लोगों को movement जो है और exercises even सिर्फ करवाना है, तो भी we use respiratory support. ऑक्सीजन के साथ, HFNC के साथ, इवन हम लोग वेंटिलेटर के साथ भी पेशेंट्स को मोबिलाइज करते हैं. So we ensure that the patients get proper respiratory support. नेक्स्ट इज मेंटेनिंग सिंपल बेड मोबिलिटी. बेड से बाहर नहीं आ पा रहे हो, तो बेड में उसको टर्न करना, पोजिशनिंग करना, प्रेशर रिलीव्स करना, ये दीज आर ऑल पार्ट्स ऑफ द बेड मोबिलिटी. एंड द आइडिया इज ग्रेडेड मोबिलाइजेशन. You cannot jump any step. You have to gradually step up your mobility program. So bed mobility जैसे मैंने बोला, simply turning into the bed really helps. अगर आप थोड़ा उठ के भी बैठ गए, free sitting is important. So this patient, for example, in the ICU critical care, the patient is sitting on the at the edge of the bed. The legs are put on a stool so that it does not dangle, and she is sitting upright. And the major thing is that the back of the patient is not attached to any surface. ये पेशेंट को हम लोग उठा के चेयर में भी बिठा सकते हैं, पर उसमें भी फायदा है. बट यहाँ पे बैठने से क्या होता है, ऐसे व्हेन द पेशेंट इज डूइंग अ फ्री सिटिंग, द चेस्ट वॉल इज एक्सपेंडिंग बोथ वेज, आगे भी और पीछे भी. सो देर इज मोर लंग एक्सपेंशन. एंड ऑल्सो the body, the core muscles of the body, the back muscles, they are learning to keep the body straight. ये बैलेंस भी कर रहा है अपने बॉडी को, अपर बॉडी को ऑन द लोअर बॉडी, और इसमें स्ट्रेंथनिंग भी हो रहा है. तो सिंपल एक फ्री सेटिंग एट द एज ऑफ द बेड इज सर्विंग सो मेनी पर्पसेस. नेक्स्ट इज अर्ली एम्बुलेशन. ऑल एविडेंसेस, जितना भी हमारे पास एविडेंसेस है, वो सब यही इंडिकेट करता है कि जितने जल्दी हम लोग मूव कर पाए सेफ मैनर. And there are certain safety precautions that we have to take when we are ambulating our patients. The lines and everything needs to be secured. Also the patients lab reports and all vitals, जो भी उनका प्रेशर है, जो भी उनके सैचुरेशन, ऑक्सीजन सैचुरेशन है, ब्लड काउंट्स है, ये सब देख के, और सेफ्टी के साथ कोई इन्फेक्शन नहीं होना चाहिए. वी हैव टू take all the precautions while mobilizing the patient. if required अपने patients को, as I said, there can be lesion in the bones also. बोन्स ब्रिटल हो सकते हैं, तो उनको हम लोग को ब्रेस, प्रॉपर ब्रेस देना पड़ता है। उसके सपोर्ट के साथ हम लोग उनको चलाते हैं, नहीं तो चलाने के टाइम जो वेट आएगा उसमें ही हम लोग को पैथोलॉजिकल फ्रैक्चर हो सकते हैं। या ऑलरेडी अगर वर्टिब्रल कोलैप्स वगैरह है किसी कारण से, डिजीज के कारण से हो या बोन लॉस के कारण से हो, तो दैट विल गेट इंक्रीज्ड इफ वी डोंट टेक प्रॉपर सेफ्टी मेजर्स। वॉकिंग एड जरूरत पड़े तो डेफिनेटली देना है। मूवमेंट हमको करना है बाय हुक और बाय क्रुक, but we will provide all walking aids, all support, all safety precautions। और अपने लिमिटेशन में रह के हम लोग को जितना होता है हम लोग उतना कोशिश करेंगे। Then exercises are most important part of the mobility. So जो 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 पॉसिबल है वो एक्सरसाइजेस हम लोग डिजाइन करते हैं। एवरी पेशेंट इज वेरी यूनिक। हर पेशेंट के लिए हमें एक्सरसाइजेस जो है बोन मैरो ट्रांसप्लांट पेशेंट्स के लिए ही नहीं, सारे पेशेंट्स के लिए ही स्पेशल वी डू टेलर मेड द प्रिस्क्रिप्शन ऑफ एक्सरसाइजेस फॉर द बीएमटी पेशेंट्स। अगर आपको जितना आपके कैपेसिटी है और जो आपके सिम्टम्स है उसके हिसाब से एक्सरसाइजेस करना पड़ता है। So here, this patient is with oxygen is doing some arm mobility exercises, as you can see. Also, strengthening exercises in bed, जो भी possible है वो हमको चालू करना है। So here the patient is using a resistance tube. So this is something which comes with different resistances और strengthening के लिए हम लोग use करते हैं। और ये अपना हीरो था। So he insisted that he will walk on his own and he was very happy. He had a very severe pulmonary GVHD, confined in the bed for a long time. And it was a really challenging case, but it was a very happy day. The first day when he walked, and he walked with his own stand. You can see the weakness little bit, the waddling gait, but he managed to walk. Next, we are coming to the phase in the post-transplant phase where graft versus host disease is more common. So that can be acute or chronic, where your own donated stem cells see the healthy tissues as foreign and attack them. So mobility का importance यहाँ पे है when the patients have got pulmonary GVHD. Pulmonary GVHD एक ऐसा condition है जहाँ पे you get shortness of breath, सांस लेने में दिक्कत होता है। There is dry and non-productive cough. Exercise tolerance बहुत reduce हो जाते हैं because you need more oxygen. The work of breathing is more. Chest में tightness लगता है, fatigue लगते हैं और recurrent respiratory infections होते हैं, specifically fungal infections होते रहते हैं। तो चेस्ट फिजियोथेरेपी हम लोग डिफरेंट करते हैं। एंड द मोस्ट इम्पॉर्टेंट थिंग इज एरोबिक एक्सरसाइज, वो भी ग्रेडेड एक्सरसाइज दैट इम्प्रूव्स द एंड्योरेंस एंड द कार्डियोवास्कुलर सिस्टम। डिफरेंट रिलैक्सेशन टेक्निक्स बताते हैं। जो द आइडिया इज टू कीप अ बैलेंस बिटवीन द एक्टिविटीज एंड द रेस्ट। सो रिलैक्सेशन इज एज इम्पॉर्टेंट एज मोबिलिटी ऑल्सो। एंड एनर्जी कंजर्वेशन टेक्निक्स बताते हैं जिसमें आपको एनर्जी कंजर्व होता है और एनर्जी कंजर्व करके ही आप मोबिलिटी रख सकते हो। तो ये एक पेशेंट अपना है क्रिटिकल केयर में, ही वाज एडमिटेड विथ सीवियर न्यूमोनिया। तो इसको हम लोगों ने चलाया विथ ऑक्सीजन सिलेंडर। ही इंसिस्टेड दैट ही विल वॉक विथ हिज टॉय कार, so we obliged. So and the same patient, he on the day of his discharge, he is very happy and without O2 room air, walking nicely. So we started mobilization as early as possible whenever it was feasible to do. The another problem is musculoskeletal GVHD, where the skin becomes very tight, joints becomes very stiff, there is pain, कॉन्ट्रैक्चर हो जाते हैं क्योंकि हम मूव नहीं करते हैं, तो वो जॉइंट्स जो है वही पोजीशन पे स्टिफ हो जाते हैं और धीरे धीरे उसमें डिफॉर्मिटी आ जाता है। तो यहाँ पे आप देख सकते हो कि ये पेशेंट ये प्रेयर साइन नहीं कर पा रहा है, क्योंकि इनके जॉइंट्स जो है ये मोड़ ही नहीं रहे हैं, ये स्टीफ हो गए हैं। और यहाँ पे ये कॉन्ट्रैक्चर हो गया है। जो रिस्ट जो है ये भी पूरा नहीं हो रहा है, खुल नहीं रहे हैं। एल्बोज भी इसका स्टिफ हो गए हैं। तो ऐसे पेशेंट्स जो होते हैं, इनके लिए मोबिलिटी इज वेरी इंपॉर्टेंट, क्योंकि इनको जॉइंट्स जो है इसको मूव करना पड़ता है, अदरवाइज ये स्टिफ हो जाएगा। तो joint mobilization is the key of management of musculoskeletal GVHD. Gentle stretching we will prescribe. धीरे धीरे स्ट्रेचिंग करना रहता है, जो हम पेशेंट्स को भी सिखाते हैं, और अगर ज़रूरत पड़े तो केयर गिवर्स को भी सिखाते हैं कि कैसे उनको स्ट्रेच किया जाता है। स्ट्रेंथनिंग एक्सरसाइजेज आर वेरी इंपॉर्टेंट, नहीं तो वो जो जॉइंट्स जो मसल्स हम यूज नहीं कर पा रहे हैं वो वीक हो जाएगा, फिर उसमें पेन हो जाएगा, फिर वो स्टिफ हो जाएगा, वही साइकिल चालू हो जाएगा। बीएमटी में हमारा एक कहावत है, जो आप रुकाओगे वही रुक जाएगा। तो हम लोगों को रुकना नहीं है, दैट इज द थिंग। एंड स्प्लिंटिंग, हाँ, जहाँ पे हम लोगों को सपोर्ट देना पड़ेगा, स्प्लिंट करना पड़ेगा, वहां पे हम स्प्लिंट करेंगे, सो दैट कि वहां पे डिफॉर्मिटी ना हो। फैटिक इज अनदर प्रॉब्लम जो हमारे ये मोबिलिटी प्रोग्राम को बहुत ज़्यादा हैम्पर करता है। वन ऑफ द बैरियर ऑफ मोबिलाइजेशन इज फैटिक, एंड दिस फैटिक इज नोन एज कैंसर रिलेटेड फैटिक। इस फैटिक में क्या होता है, अब जितना सोते हो आपको उतना ही सोने का मन होता है। सो द फैटिक इज नॉट रिलीव्ड बाय रेस्ट। दैट इज द डिफरेंस बिटवीन नॉर्मल टायर्डनेस एंड कैंसर रिलेटेड फैटिक. Normal tiredness after a day's hard work, if you're feeling tired, if you take rest, your tiredness will be gone. But for cancer related fatigue, more you rest, there will be more fatigue. तो इसका एक ही इलाज है, वो है मूवमेंट। देयर आर लॉट्स एंड लॉट्स ऑफ एविडेंसेस, बहुत सारे स्टडीज हो चुके हैं और बहुत सारे हमारे पास इसका प्रूव है कि एक्सरसाइज करने से एक्चुअली आपको अच्छा लगता है। द फैटिक गोज डाउन ओनली विथ एक्सरसाइज। फैटिक सीवियर हो सकते हैं, मॉडरेट हो सकते हैं, माइल्ड हो सकते हैं, कैसे भी टाइप के फैटिक हो। अगर ये सीवियर फैटिक है तो वो मॉडरेट हो जाएगा, अगर मॉडरेट फैटिक है तो वो अ, और भी माइल्ड हो जाएगा, और अगर माइल्ड फैटिक है तो उसका एपिसोड भी बहुत कम हो जाएगा। सो अगेन एनर्जी कंजर्वेशन टेक्निक्स हम लोग सिखाते हैं, एंड स्ट्रक्चर्ड एक्सरसाइज प्रोग्राम। फैटिक के लिए हम लोगों को पूरा रूटीन बना के देना पड़ता है, नॉट ओनली फॉर द फैटिक बट ओवरऑल फॉर द बोन मैरो ट्रांसप्लांट पेशेंट्स, कि व्हाट आर द एक्सरसाइजेस दैट यू विल डू, हाउ यू विल पेस, कितना आपको रेस्ट लेना है और कितना आपको मूवमेंट करना है। देन रिलैक्सेशन टेक्निक्स हम लोग सिखाते हैं, एंड देयर इज ऑक्सीजन थेरेपी। ऐसे मैंने बोला, विथ रेस्पिरेटरी सपोर्ट देयर हैज टू बी ग्रेडेड मोबिलाइजेशन, एंड ऑल्सो ओवरऑल मूवमेंट मोबिलाइजेशन का है साइकोलॉजिकल बेनिफिट। Again, there is lots of proof that when you do exercises, when you do move, then your brain secretes happy hormones. तो ये hormones जो है ये अपने मूड एलिवेट करता है, सेल्फ एस्टीम कॉन्फिडेंस बढ़ाता है कि मैं चल सकता हूँ खुद से, मुझे किसी की हेल्प लेने की ज़रूरत नहीं पड़ रहा है, या मैं डिपेंडेंट नहीं हूँ। अगर मैं डिपेंडेंट हूँ भी तो माइल्ड मुझे डिपेंडेंस हो रहा है, क्योंकि मैं मूवमेंट कर पा रही हूँ। इसमें एंजाइटी, स्ट्रेस एंड डिप्रेशन गेट्स रिड्यूस्ड ऑल्सो, फैटिक रिड्यूस होता है, एंड आपका स्लीप जो है वो अच्छा होता है। स्लीप इज अ वेरी इंपॉर्टेंट पार्ट ऑफ योर डेली रूटीन। सो lack of sleep will cause a whole series of complications, but if you do exercise, if you do move, then the sleep quality improves, एंड ओवरऑल द योर कॉग्निटिव फंक्शन, मतलब आपका सोचने का, समझने का, आपको कोई भी फंक्शन एग्जीक्यूट करने का जो पावर है वो इम्प्रूव हो जाते हैं, एंड योर ओवरऑल क्वालिटी ऑफ लाइफ गेट्स बेटर। और ये जो मैं बोल रही हूँ, जैसे मैंने बोला कि ये सब एविडेंस बेस्ड है, बहुत सारे स्टडीज है, और वहाँ पे देखा गया है कि प्रॉपर एक्सरसाइज इंटरवेंशन मोबिलिटी अगर आप मेंटेन करते हैं तो ओवरऑल आपके फिजिकल परफॉर्मेंस, क्वालिटी ऑफ लाइफ, फैटिक स्टेटस इम्प्रूव होते हैं, एंड ऑल्सो बेनिफिट्स लाइक फास्टर रिकरेंस ऑफ इम्यून सेल्स, इवन अपने आपकी इम्यूनिटी अच्छा होता है, एंड रिड्यूस द सिविरिटी ऑफ थेरेपी रिलेटेड साइड इफेक्ट्स। जो भी ये बोन मैरो ट्रांसप्लांट की थेरेपी रिलेटेड इफेक्ट्स है वो भी रिड्यूस्ड होते हैं। सो एक्सरसाइज एंड मोबिलिटी का फायदा ही फायदा है, बट देयर हैज टू बी सम सेफ्टी कंसर्न्स, जो हम लोग कंसर्न्स को मद्देनजर रखते हुए आपके एक्सरसाइज प्रिस्क्रिप्शन करते हैं या आपको मूवमेंट करवाते हैं। तो उसमें हम लोग मॉनिटर करते हैं अपना प्लेटलेट काउंट्स एंड हीमोग्लोबिन, आपके वाइटल्स जो है, बीपी, हार्ट रेट, ऑक्सीजन सैचुरेशन, ये सब हम लोग मॉनिटर करते हैं, और ये सेफ लेवल में रहेगा तो ही हम लोग कंसिडर करते हैं कि आपको कितना मोबाइल करना है या कितना एक्सरसाइज करवाना है। इन्फेक्शन
Right.
कंट्रोल प्रिकॉशंस लेना जरूरी है, एंड ऑल्सो एवरी पेशेंट इज डिफरेंट, तो सबके लिए एक्सरसाइज प्रिस्क्रिप्शन में कुछ ना कुछ ट्विस्ट रहता ही है। So the key take home message is that the mobility is an essential support care in BMT patients. Even low intensity activity provides benefit. कुछ तो करो, थोड़ा सा भी आप मूवमेंट करोगे तो भी उसका फायदा आएगा। सेफ, अर्ली एंड इंडिविजुअलाइज्ड मोबिलिटी इम्प्रूव्स रिकवरी। तो मोबिलिटी विल हेल्प यू टू रिकवर फास्ट, एंड इट विल रिड्यूस योर लेंथ ऑफ हॉस्पिटल स्टे। जितना कम हॉस्पिटल में रहोगे इन्फेक्शन उतना कम होगा, इतना जल्दी घर जाओगे, घर पे अपने एटमोसफियर में आप और भी अच्छे होते रहोगे, एंड इम्प्रूव्स क्वालिटी ऑफ लाइफ। सो ओवरऑल mobility is a very important and essential supportive care in BMT patients.
Thank you so much, Dr.
Thank you.
Mahua. That was so wonderful. You took us through the entire gamut of what it means to be mobile throughout this journey. Thank you for the wonderful videos that you shared with us, great success stories. I'm sure all the patients would feel mobilized and motivated to be mobile. Also, I want to especially thank you for addressing everyone in Hindi, because that gave us all a personal touch about how much involved you as a caregiver are in terms of making that journey to recovery for all our patients. We now move on in more depth about this wonderful topic that Dr. Mahua has introduced us. To take us through the panel discussion, I welcome Ms. Meeta Roy Chaudhary, Chief Nursing Officer, Apollo Surgery Super Speciality Hospital, Sonarpur, West Bengal. And to join her as our esteemed panelists, we have Dr. Indra Jaikumar. She's a senior consultant and lead pediatric intensivist, Apollo Speciality Hospital, Chennai, uh, and also a co-convener of the IIT Transplant Critical Care Group. Dr. Smita Elizabeth Joseph, Associate Professor, Department of Physiotherapy, St. John's Medical College and Hospital, Bangalore. Dr. Mahua Chatterjee herself, and Ms. Snigdha. She's a human resource specialist, Tech Mahindra, Hyderabad. Over to our moderator and panelists to initiate our panel discussion for this particular topic.
Thank you so much, Dr. Venkatesh. Good afternoon to you all for nice introductions. And patient actually who has undergone HSCT, his journey is very complex and associated with various type and varied degrees of complications that increase the risk of functional impairment. And in many cases, it lands up with long-term functional incapacity. It is significant and impact is very much negative, as we all know it. So in this panel discussion, we shall be looking into the various, mobility, immobility issues, as well as your assessment, early recognition.
Kindly share your video as well.
Yeah, right. I'll do that. I'll do that. Am I seeing it? So early recognitions and then mitigation of these problems, restoration of the functional capacities, as well as good quality of life, what we can offer to these patients. So without taking much time, I shall be just sharing my slides and move to questions. Slides are visible?
Ma'am, slides are not up. You'll have to share the slides.
Oh, it's not up. Okay. Can you see the slides now?
Yes, ma'am. Now they are loaded. Just
Okay.
put
You just
the.
have to click on the slide show.
Yeah,
Yeah.
it is already put
Yeah,
on slideshow.
yes.
And
Now we're-
once again, I would like to cordially invite all the panelists, as already introduced by Dr. Venkatesh. So my first question goes to, slides are moving. Yeah, goes to Dr. Indira Jayakumar. Hi, Dr. Indira Jayakumar. Question is like, how do you define critically ill patients in HSCT setting? That's my first question. Second question, what are the impacts of immobility in critically ill patients? And how do they show up at the earlier phase as well as the later phase?
Good afternoon, everybody. I hope I'm audible. Thank you, ISBMT, for this invite. I've always found your patient support webinars very practical and useful. And Dr. Mahua Chatterjee has actually beautifully, explained the importance of mobilization. So now, a very important thing, mobilization, when we talk, it's not equal to ambulation alone. So it doesn't mean only walking. Any movement is mobilization. So I've been looking after the sick transplant and cancer children for the last 6-7 years in the pediatric ICU. And there have been many studies, evidence to show that this really helps sick children who are hospitalized with any for transplant, for oncology, cancer, etc. So there have been studies called PICU Up, and then there is another brave study. So be brave and move. So begin restorative activities very early. That is the mnemonic brave. And Dr. Mahua actually explained how immobilization, not moving, can actually affect your mind, body, as well as the soul. And whatever she mentioned holds good for any individual who remains immobilized, more so in ill patients because they're frail, cachectic, and children even more so because children generally move. They are so active and they're not used to being, just sitting in the beds, sitting on the bed. So you asked, who are the critically ill patients in transplant? Now, transplant children pre-transplant also can be unwell. They can have organ dysfunction because of cardiac iron overload in the liver. They can have infections. Immune deficient children can have infections, and they need varying degrees of life support, oxygen, HFNC, etc., invasive monitoring. So all this, prevents them from mobilizing. Post-transplant, after they get their stem cells, they can have your cytokine storms. So they can have fever, breathlessness. They can have engraftment. When the counts go up, again, they can become breathless and have fever. They can have abdominal distension because of sinusoidal obstruction syndrome and big liver. Now, TATMA, severe hypertension, requiring so many antihypertensives, even IV antihypertensives. And so nobody wants to move a child with such high blood pressures. Then gut GVHD, mucositis, with so much of diarrhea, the child becomes tired, not able to eat. So that's another issue. Then sepsis, infection is so common in HSCT. And of course, drug-induced problems also. Also, to be mindful that these are not just ordinary, children with some illness. They already are very frail. They are catabolic. They are nutritionally compromised for a long period. And they are also have lack of motivation because of extended hospital stays and repeated periods of, bouts of being unwell. So impact of immobility, I'm not going to again explain what Dr. Mahua said, but it's the brain, mental well-being, depression, sleep. They're not able to sleep. Your lungs collapse, muscles wasted. Within 2 to 3 days of getting admitted, if you don't move, the muscles start wasting. And when muscles start wasting, you can't move, you become more weak, and it becomes a vicious cycle because they feel so weak, they don't move. And again, this immobilization actually, causes more weakness. Giddiness when standing up. So they are really frightened because they have anemia. They may feel giddy, and so they may not be frightened to move. So this has been shown that you can have loss of acquired milestones in children. So children can actually regress both mentally, their motor milestones can also regress. They can have mood swings, and getting back into normal childhood and activities can become harder and harder if we are scared, if parents are scared, or caregivers, doctors, nurses are scared to move our patients.
Absolutely. Very right, rightly said by Dr. Indira. And one more thing, like in autologous setting, you might be seeing very geriatric population. They are undergoing the autologous transplant. Most of the time, they have got, cardiorespiratory, it is being compromised. Echo, they don't even come up to that level of echo, what value you're looking into, or maybe your, cardiac reserve, what do they have? Even lung reserve also is not that good. That is one thing. You might modify the drug, but the respiratory, I mean, the support, physical support should start from the day one itself. That's very important. Thank you so much. I'll move to the next question. Sorry. Next question to Dr. Smita Elijaveth. It's what are ICU acquired weakness? If you kindly tell us in elaborative manner.
At the outset, thank you, ma'am. Thank you all, the entire team, for inviting me to be a part of the panelist group. Now, I'm not going to waste any more time directly to the ICU acquired weaknesses. We see, as our previous speakers have already elaborated on the various causes that induce immobility, that are associated with the immobility, the physical illness, the children, especially when we are looking at the children or the geriatric population. Among them, the females are more prone towards the critical illness, acquired weaknesses. Okay, then there are a lot of comorbidities that these patients have, and these include the comorbidities. They actually include the multi system failure, the multiple systems that are involved. Each system, the failure of one system leads to immobility in the other system, and then it becomes a vicious cycle. And there can be as simple as any insulin resistance can cause a decrease in the availability of sugars, and the availability, basically, to put it in a layman's term, the availability of nutrition to the muscles, and that can lead to a lot of weakness. And this weakness can be reflected in the form of either a polyneuropathy, a critical illness induced polyneuropathy. That means the nerves are affected, or it can be in the form of a myopathy, the muscles are affected, or it can exhibit as a combination of both, where it becomes more critical, it becomes more severe for the patient who is undergoing that. It leads to a lot of difficulty in moving, in simple activities like moving the limbs, in swallowing. And when swallowing is affected, the nutrition gets indirectly affected. That again brings a what to say, a deterioration in the nutrition that is going into the child or the patient, and that can lead to more problems as it goes ahead. So at the outset, we have to start early mobilization. Both the speakers who have spoken before me have emphasized early mobilization, and we will be discussing about that in further also.
Thank you. The second question to Dr. Indira once again. Like, as you already explained, in general, patients staying in ICU, the complications they develop. But what are the transplant specific factors that contribute to these complications? It could be from the starting from the conditioning, then the soon after stem cell infusion, before engraftment, soon after engraftment, and later phase of engraftment. So, what are the transplant specific factors can contribute to this kind of complications? If you kindly elaborate on that.
So transplant related, first is the underlying condition for what the transplant has been done for. Then after that, your drugs, your conditioning drugs. So we know drugs are cardiotoxic. They have other side effects as well. They can cause pain. So all that itself will affect the patient's child's well-being. Then the main distressing thing is pain, mucositis. I think that is the most common problem, and actually not often, doesn't get the importance that it really deserves, because the child is not able to eat, the child is not able to swallow even the saliva, so much of pain. No child will want to move or ambulate when you are having so much pain, and you're weak because you are not able to swallow or take normal nutrition, which the child was taking even before the conditioning had started. Then they are undergoing so many procedures. So these are the other things. For every time there'll be central line, there'll be bone marrow, they have diarrhea. So, it can be initially due to mucositis, and afterwards it can be because of gut GVHD, or it could be due to gut TMA. Severe diarrhea. So for prolonged periods, the child can just be on parenteral nutrition, not taking anything orally. The thing that happens is slowly the child feels unwell and physically, then it becomes mental. So then there is mood swings because the child is not able to sleep. There's temper tantrums because they can't understand. It seems to be going on and on, so prolonged, all this illness, and they can't understand why. So we've seen children, parents giving the smartphones, the TV or the iPad to these children, and they are they find this is the comfort space, because then it takes them away from all the other problems that they see the monitors, the lines, the nurses with the needles and medicines. And I feel the best way to mobilize HSCT or prolonged stay patients, you move the phone, you move the iPad, and along with it they will follow, because as long as they have it with them, they are not going to move out of the bed, because this is their comfort space, and it is more a mental, something like a comfort blanket they are holding on to. So the barriers in stem cell transplant is the disease. So it's physical disease before transplant, and then after the transplant, it's psychological, and then logistic. So logistic issues as well, because you don't have enough staff. The parents are worried because they're seeing so much, something new, which they had never, they're not prepared for all these. So they feel, what if the child falls? My child has anemia, my child is feeling giddy, maybe I should not move, the child is better on the bed. And there is the fear from the caregiver, the nurses, the doctors, because it's not a culture thing, and more so the parent and child. And then the child also realizes maybe it's better safe on the bed, not moving too much. So I think there should be a different
they just succumb to the bed only. They just don't want to move out. Even a child, he explained, there was total perineal area was, it was torn, and there was abrasion. He's telling, like, after passing stool, my experience is like you put a matchbox burning on my skin. That is the experience I have it, because stool is acidic, that will make your skin totally, there's abrade. So that was the experience, and actually it hampers, absolutely jeopardizes the activity of daily living. First thing what happened, and the deterioration you find in child, it is more faster than the adult. That is one thing. So that was the thing. Thank you so much. I'll move to the next question to um, Dr. Mohua. Dr. Mohua, it was very nice presentation and very simplified manner. You have, told all the solutions, and demonstration was very nice. The question is like, what are the rationale for mobility in critically ill patients undergoing stem cell transplant?
So, first of all, as I said that the main aim is to prevent, prevention of the deconditioning. If someone is confined in the bed for a long time, so the deconditioning happening in the muscles, and the cardiovascular insufficiencies happening, respiratory complications happening. So we need to prevent all these things. So the aim of mobility is to prevent. And then if it is happening and we cannot completely nullify the side effects of the drugs, like steroid to deny parega. So all these things we need to adjust, and the mobility and exercises needs to be graded and tailor made, suiting the need and the symptoms of the patients.
So it's like, what are the goals? What are the benefits of mobility in such patients? In nutshell, if you can just tell us.
So the benefits is, first of all, maintaining the muscle girth, to reduce the disease atrophy, and to improve the muscle power. The joint stiffness needs to be prevented, and to prevent the pulmonary complications, improve the mental health of the patient, and overall to improve the quality of life.
Fair enough. Thank you. Let me move to the next question to Like physiotherapy, as you already told, it has to start early and it should be progressive in manner and overall goals and activities through various phases of transplant, like pre-transplant, immediate post-transplant, and discharge and rehabilitation. Dr. Smita, can you please tell us what approach, assessment, and progressive activities to be included in the like precondition phase as well as the acute phase where the patient is being transplanted, may or may not be engrafted. That is immediate phase. That is acute phase actually. What should be the approach?
So actually, the approach should be based on as early intervention as is possible. Once the child is actually medically stable, with, we have to start with the early interventions as early as, if possible, within the first 24 hours after stabilizing the child or the patient. And then it should be individualized based on individual assessments. It should be tailor made. No, if you cannot apply the same kind of activities to do two different children, it should be individualized. Based on how do you individualize this? Based on the assessments that you do, you have to do individual assessments based on all the different systems, like your cardiovascular system, the musculoskeletal. You check for the muscle power, you check for the range of motion that is available, how much the child is able to functionally perform, the balance that is available in the balance act, how much balance is there available in the child, the functional mobility that the child is able to perform, whether there is any cognitive decline, whether the child is able to understand your commands. And based on all that and the radiological investigations, the different investigations, the lab investigations that are performed, based on all that put together, you can chart out a protocol for the child. And when you are doing the phase wise mobilization, it has to be like, you have to first start with the passive movement, the passive mobilization as much as is possible if the child is not able to perform any activity individually or actively, and then slowly progress it to active assisted. Encourage the child. It may not be in the form of a regular exercise. Depending on the age of the child, you can include it as a play therapy, as like ma'am had rightly said. You try to move the smart device, the child will automatically start moving along with that. So that can also be employed. It is the caregiver, it is between the caregiver and the child, whose help we have to take to chart out the protocol for the child. And then after moving from the active assisted phase, we move on to the active phase, where the child will be able to perform activities on his own. He understands the pattern of the movement that has to be performed. The caregivers understand the pattern of movement. And from there, we can move on. And based on, like, after the acute phase, like once the transplant is done, we have to ensure that the continuity and the compliance is maintained. That is more important.
You just wanted to clarify, like in the precondition phase, almost all the patients are quite like they're in good shape. Then only we take them up for the transplant, unless very elderly or some now emergency you're doing the transplant. So such cases, like as a nurse, what we used to advise, like for your incentive spirometry, they should do it. They should build up good nutrition and then should maintain good walking and these things. So is it all right to do that in preconditioning phase?
We have to educate. We have to give an awareness, basically improve the awareness of the patient and the caregivers of what to be expected in on as the days move ahead, and what can be the complications, what are the risk factors. Educate the patients, basically the patients and the caregivers, so that they are well aware and they are well equipped to handle the situation as and when it comes in. So if
Actually,
incentive spirometer and all will help to maintain the bronchial hygiene. It will help to maintain the oxygen saturation, which is very
yes.
important for these patients.
When ROM also, full range of motion exercises, if they can do it, yes. Bone strengthening, muscle strengthening exercises from beginning itself, if they can practice before they become very sick, if that can be done. Thank you so much. Next question to Dr. Mohua. And what are the long-term goals of physical therapy during rehabilitation process? How do you take care of physical and functional health of chronically ill patients in later phase of transplant? I mean, keeping in background the chronic diseases, what happens in the post-transplant phases.
So, in the long term considerations, here the patients have moved from the critically ill condition to a chronic condition where some of the problems will keep on coming back. So, there can be chronic GVHDs, As I said, the musculoskeletal GVHDs can really hamper their daily activities. So we have to have a close monitoring and follow up of the patient. That is very much important. Even if the patient is discharged from the ward, discharged from the hospital, and they are on follow up, so every time the patient comes to the OPD, the patient has to visit the physiotherapy department, and we do a thorough assessment and see now when a patient has gone back to their home and their previous activities, what are the problems the person is facing. So depending on that, we identify that what are the areas where we have to work. Like if a patient is having difficulty in getting up from the chair or climbing upstairs, or the patient is feeling difficulty in sitting long term and doing some computer job, so we have to identify the weak points and we start doing the strengthening exercises. It is the time when we escalate our intervention. So in the critical care unit, we have to be very careful and cautious while we are doing the mobilization exercises or our therapy. But here now we can take little liberty because the patients are hemodynamically stable now, and they are having a good lab reports, but they need more. So their functional capacity needs to be improved. So we escalate our intervention process to a little bit more vigorous state. So the strengthening exercises are more exemplified, and as well as the balance training, as I said. Then we have to take care of the pulmonary health as well. Maintenance is very important, and if the patient has already got some fibrosis because of the pulmonary GVHD, so those parts are not taking part in gaseous exchange. So we have to improve the function of the healthy parts of the lungs. So breathing exercises as well as different secretion removal techniques, these things needs to be taught to the patient and caregiver so that they can keep on doing this thing. And also we encourage them to go back to their previous fitness process. If suppose a patient was going to a gym earlier, maybe we can ask him to start that in a controlled environment, preventing the infection, but as well as resuming their previous routine. That gives them immense confidence, especially nowadays, teenagers, the boys who come to us, and they say, okay, I'm not feeling good because I cannot go to gym now. पहले तो मैं ये करता था, वो करता था. So this that gives them depression. But once they start, even with in a very small scale, that boosts up their confidence. So the aim
Thank
of
you
long
so
term,
much.
yeah,
Yeah.
long term
I
goal.
am
Pardon?
yes, continue on. Please
So the
finish.
long term goal is to make them feel confident and as close as possible to their previous health status.
So, Dr. Venkat,
Sorry
we
to
have 5 more time means time
sorry.
to continue.
We have only one question that we can take.
Okay, then I
We are
will go
actually
to I will talk to Snigdha, I think Miss Snigdha, to take her
yes,
question.
please be
Okay,
Ms.
I'll
Meghna,
just
ma'am.
talk.
And that will be the last, probably the last
Yeah.
question because we have already overshot our time.
Yeah, right. I understood. So, Miss Snigdha,
Thank
can you just tell us what was your experience during your transplant journey, and what are your unique observations? What could have made you more, better things could have been done in respect of your functional recovery as well as your quality of life?
Got it. Thank you so much for the question, and thank you all for letting me be a part of this discussion. And I'm learning so much more as to whatever the doctors have spoken in terms of, what exactly we go through. So I could relate to every single thing, whether it's the neutropenia or the neuropathy, myopathy. I've experienced all of it. So it was very insightful as to what more the doctors have shared. So it's been 10 years since I underwent stem cell transplant. And my donor was my first cousin from my father's side. And if I can talk about my journey, and to be very brief, of course there's lots to share, but just to be brief and stick to the questions. Yeah, during so the conditioning took place, and there was one chemo drug involved, and there was a total body radiation TBI involved for I think 2 or 3 days. The chemo drug did cause cardio complications, as rightly said by one of the doctors. My heart rate went very high, my blood pressure came low, and they had to call in the cardiologist, and they probably gave a beta blocker. It was very painful experience, but yeah, I was fine actually after that, and they discontinued that chemo drug. So conditioning, this was one particular complication during conditioning. But yes, the after transplant, of course, I didn't develop GVHD actually. I didn't develop GVHD, so I have no experience of how it is. But of course, I've seen other patients having, most of them develop the skin GVHD, and then maybe a few with the gastric issues. After, yeah, my transplant, I the only thing, yeah, I did struggle with, not being able to eat, throwing up, whatever was eaten. So even I took that TPN, the TPN packets for a couple of days, and all of that. Yeah, I did have a lot of weakness, of course, during the transplant. After transplant, I didn't experience any myopathy, neuropathy. It was more to do during my chemotherapy, the first phase of chemotherapy, which I had about 6-7 months ago. But yeah, the general weakness, and of course, being isolated from people. But what I would also say is we were much more mentally prepared compared to what it was during the first phase of chemotherapy, because that was an absolute shock to everyone, mentally, physically, emotionally. And I remember being very mentally down after the first phase, because continuous 45 days of hospitalization and a lot of strong drugs to kind of counter the disease, which is extremely what do you say, aggressive. So I was treated for acute lymphoblastic leukemia, ALL for short. What else can I say about my transplant? Yeah, I got utmost support. I didn't struggle
Tell
with
us about your physical rehabilitation, if you can share a couple of
physical
points.
rehabilitation. There was actually nothing in specific that was part of the protocol, actually, if I may say. There's nothing that the doctor said that you need to do these kind of activities. I was in my isolation ward, of course, a little bit of walking I was doing. There was no such physical rehabilitation protocol that was kind of advised to me. That's why I'm not able to recall, I don't think there was any such
Post
protocol.
transplant, were you able to resume your normal physical fitness activities? And how long did it
Yes, yes,
take for you?
it took some time. So since I didn't develop GVHD, I was 1 month in that, the isolated BMT ward. And then, so this was in Vellore in Christian Medical College. That's where I received the stem cell transplant treatment. So we had rented a house there. So every week we would go back, get the test done and all of that. So yeah, I was able to gradually regain my strength, my appetite, my strength and all of that. But of course, I was not immediately back to my normal physical fitness. It took quite some time. I think over the next year I took a additional medical leave of 6 months, and then resumed work. So I was fine. I mean, I didn't have the strength. Like, I do remember having my weakness in my knees, because after the first month of chemotherapy, I couldn't climb the stairs. I had major weakness over there. So that slowly, that also took time. I was not able to climb a very high, a steep step. That I did
Right.
experience, but then it got better later. It got a little better. I resumed my normal activities. I've never been a gym goer, but I have always I do a lot of walking, and in fact, after COVID started, my mom and we started going for 5K and 10K runs. So that way, you know, I was, yeah. We have a lot of medals in the house. We've collected so many of them. So yeah, gradually, I think it took about a year's time for me to also feel confident about stepping out, you know.
journey.
Stepping out and all of that. That's what I can say.
Thank you so much, Snigdha, for sharing your personal journey and the thoughts. And I thank everyone for such a wonderful discussion, wonderful interaction. Unfortunately, we are so short of time already. And I invite our members to move on to a vote of thanks. Dr. Santosh Devdas, kindly take over for the vote of thanks. Thank you so much.
Thank you, Dr. Venkatesh, and thank you all the discussants who took forward this discussion. It was even a very good learning experience for me. Rashmi, can you share the slides? I have worked with Dr. Mahua, and I know how well she takes care of the patients in the unit in ATRAC. Thanks, Dr. Mahua, for the wonderful presentation. And I also thank Smita Roy Chowdhury, Dr. Indra Jaikumar, Dr. Smita Joseph, and Snigdha for sharing your experiences with us. Though we are in transplant and we see patients daily, it was quite a enlightening experience even for ourselves. I thank the sponsors, Genova Biotech and Novartis, and Cipla Oncology for sponsoring this webinar. And we look forward to having all of you, the caregivers, the patients, for our next webinar on 14th of February 2026, webinar number 18, and we'll soon get back to you with the topic. Thank you.
Thank you.
Thank
All
you
right.
so much. Thank you all of you.
Thank you, everyone.
Thank you.